All right, well, thank you so much, John, for that introduction. And it truly is my pleasure and honor to be here and share some of the tips that were passed on to me by the true masters of testis pathology with you guys today. So here we go. And like John said, please make sure to put all your questions in the Q&A box and don't use the chat function. All righty, so for some reason I can't advance. There we go. So the structure of this hour is really 40 minutes of me talking, but really I want to give 20 minutes of time to you guys because there's no way we can cover all of testis pathology in an hour. So I'll make sure I sort of give you some tips that I've learned, but also sort of give you guys the opportunity to talk about what you guys want to talk about. And I look forward to the day that I actually have this. All right, so first and foremost, I just want to briefly mention grossing because in my opinion, grossing is truly the foundation of good pathology practice. Now, Chinese people have a saying, it's, you try to win at the starting point. So really before good grossing, there's prompt fixation, right? Because if the tissue is not properly fixed, no matter how good the grosser is, your tissue section is just not going to turn out great. So to maximize your success in diagnosing testicular pathology, I would say prompt fixation is really the key. So really good fixed and really good grossed testis tumor is really going to be much easier than a poorly fixed, unfortunate section. Now, I always get the question, okay, what's an adequate submission of testis tumors? For me, as a person of interest with testis, I always say, just submit the whole thing if you can, but in a reasonable and practical sense. The guidelines are if it's small enough, less than 2 centimeters, you put it all in, or if it's slightly bigger, but you can put it in 10 blocks, you put it in that, right? Now, if it's a larger tumor, you just can't put it in, but at least you put in 10 blocks of tumor. So that's not counting the margins and all that, at least 10 blocks of tumor or a minimum of 1 to 2 blocks per centimeter. But really the key is good fixation of the tissue, as is with any organ systems, really. All right, so number one tip for grossing, I personally always recommend checking the serum tumor markers in 2 situations. For the primary, as illustrated here, especially if it's a bloody specimen, sometimes necrotic, a good grosser typically will avoid those areas, right? They'll go for the solid and fleshy areas. However, in the context of germ cell tumors, for instance, if you have really elevated beta HCG, then you really want to get a lot of bloody sections, right? So the grosser will technically know to do that unless they check the serum tumor marker. So that's one context of the primary. Another example would be in an RPLND. So a post-chemo resection, partial peritoneal lymph node dissection, usually the teratoma would be left over, but really the tumor that's of importance is actually a non-teratomatous type. Now, when you look at the gross lymph node, for example, if there's teratoma, usually the teratoma will be very overwhelming, so they'll be very obvious. Cystic, fibrous, you'll just get distracted by the teratoma when in fact the more important would be, for instance, yolk sac tumor, embryonal, seminoma that's left over, choreo, and those you would really know to look for unless you check the serum tumor markers. So one, check the serum tumor markers to see if there's elevated AFP, if there's beta HCG, and you sample the specimen appropriately. For instance, if it's a yolk sac tumor, you generally would see AFP elevation, and knowing that you want to look for the solid fleshier areas and sort of mentally ignore the teratoma. So that's how I use serum tumor markers in conjunction with grossing the testicular tumor specimen. Now, cord sampling is something that I want to mention. So you see two arrows here. One on the top is referring to the cord margin, which the guidelines is you would want to do an en face section of the cord margin. I've seen rare instances where people are taking radial sections, and I don't really recommend doing that. Even if you see tumor really close to the margin, I would just always say, just do an en face section of the cord margin. So that's number one. Number two is the second arrow down here, where it's just a section of cord that is immediately above the head of the epidermis. And I like to be very specific about that section, as I'll show you an example of why that potentially would matter. But before I go on to the next slide, I also want to mention you do want to make sure you get interval sections of the spermatic cord as well. I've seen some cases where the only cord sections I see are really the one section here, and maybe if I'm lucky, I get another section sort of in the middle of the cord. But my recommendation is you sample the cord, and then you sample another cross section, maybe 1 or 2 centimeters after that, and another one after that. So I would like to see sort of an interval sectioning of the entire cord. If possible, but I think it should be done just to catch that maybe a little bit of lymphovascular invasion that you see in the cord that may not be visible grossly. So that's the purpose of that. Now, let me show you the reason why I want to put some time talking about this section of the spermatic cord immediately below the head of the epidermis is illustrated in this case. So this section came as hilar fat. Seminoma, large mass involving the hilar fat. So this was taken as the hilar fat. So there's no doubt that there's going to be hilar fat invasion. Now, what's interesting is that here on the top of the screen, you're seeing that a portion of the vas deferens is here in the same section of soft tissue invasion. So when you go back and look at the gross, that is really the beginning of the spermatic cord, right? So, if a tumor is here close to the hilar, when does the hilar fat end and when does the spermatic cord begin, right? So generally, the tip that was passed down to me was that you sort of look at the vas. So the beginning of the vas is considered the beginning of the spermatic cord. So that's why, in addition to taking a section of the epididymis, I would say give me a section of the hilar fat / cord above the head of the epididymis. And as you'll see here is really close to the beginning of the vas deferens, right? So, if for whatever reason you see a case that large tumor, hilar fat involvement microscopically or even grossly, however, in the same plane, you're seeing soft tissue invasion at the level of the vas deferens, that counts as spermatic cord invasion. So that's why I wanted to take some time to talk about that. All right. Number 3, grossing tip, sample the tumor interface, right? So yes, I know, a lot of us will sample the tumor, of course, different areas, fleshy areas, hemorrhagic areas, fibrous areas, but don't forget to put in a couple sections of tumor to the interface as highlighted in these 2 examples here. And that is because that section is going to be the highest yield in looking for lymphovascular invasion. So, and lymphovascular invasion, briefly mention it, what counts as true lymphovascular invasion. This is an example of true LVI, where you see a cohesive nest of tumor contorting itself to fit into the luminal space. That counts as true lymphovascular invasion. And for most of us, the most common one will be embryocarcinoma. Of course, you're going to see other types of tumor with lymphovascular invasion as well, but usually embryocarcinoma is the easiest and most common one to identify. And really, again, just having that junctional section really maximizes your chance of finding really good LVI. Now, this is an example of fake out LVI. So this is not LVI. And the reason for that is this is not a cohesive nest of tumor. And 2, just being aware that so the tumor on the right-hand side is seminoma itself is very, very friable. It really gets everywhere. So going back to good grossing habits, if the tumor is really necrotic, then what you want to do during grossing is make 1 cut, wipe your blade before you make another cut to limit the amount of contamination or the so-called buttered on effective tumor. But I mean, in reality, there's just no way to avoid it completely, but at least we can try to minimize it as best as we can. So that's fake out number 1. Fake out number 2 is, sometimes we'll see histiocytes in the luminal space, but even if we confuse this as tumor cells, this still doesn't count as true LVI because it is not a cohesive nest, right? There's no contortion of it happening either. So regardless, this is not true LVI. Now, this is the slide where I would say is really the gist of testicular tumor pathology, where I separated out based on different categories of tumor and really what's the most important points sort of across those three categories. So number one, and the most common germ tumor that you'll see is really germ cell tumors. And of course, again, we're going to focus on the adult, mostly on the adult population within this category. So 95% of the tumors will be germ cell tumors, 4 to 5% will be sex force stromal tumors, and 1% will be others. Now, the important thing in my mind is to, when you have a testis tumor, is really just to put it in the right category, because really, once you have the correct category, generally the treatment type is the same. So I've noted a few exceptions. So in an adult germ cell tumor world, most of the tumors will be chemosensitive, right? So in addition to primary tumor resection, which is radical if there's metastasis, most of them will be sensitive to chemo, with the exceptions of teratoma, somatic type malignancies, yolk sac tumors, etc. But in general, germ cell tumors are responsive to chemotherapy. Now, people ask, well, seminoma. Well, seminoma also responds to chemotherapy, right? It's just that in addition to that, they also respond to radiation. So again, germ cell tumor in adults, most of them are chemosensitive. Now, sex force stromal tumors is just the exact opposite of germ cell tumors, right? Because they are chemo resistant. So chemo can't kill sex force stromal tumors. So you need to actually surgically cut them out. So if it's a sex force stromal tumor, really the treatment is surgical resection, no matter what type of sex force stromal tumor you call it as, right? So the important thing about sex force stromal tumors is, one, knowing that they're chemo resistant, surgical excision is the standard treatment. And last but not least is trying to help our clinical colleagues identifying which ones are overtly malignant, right? Because if in those cases, then maybe they want to consider early RPL&D, even without radiographic proof of metastasis. So that's the important thing in the category of sex force stromal tumors, is just understanding most of them are going to be benign, but trying to identify the rare ones that are actually truly malignant, where they might need additional follow-up or additional surgery. Now, those are going to be large tumor size, tumor necrosis, really ugly, obvious cytologic atypia, lymphovascular invasion, as well as high mite count, and some people might add infiltrative growth pattern is another feature that is highly suspicious from malignancy, right? So those are the important things to know for sex force stromal tumors. And then the last category is really metastasis, lymphomas, sarcomas, etc., peritesticular tumors, things like that. And the treatment for the others category is really just dependent on what type of tumor it is, what type of disease process it is, right? Now, for us, in a case of metastasis, there are a couple of morphologic things you can sort of pick up on that'll help you know that, oh, we're thinking about maybe this is the met. And those are really prominent reedy testis involvement, as well as really easily identifiable with vascular, right? So in general, when we have a testis tumor, will be a germ cell tumor, and we would be like scouring, trying to find one really good LVI, right? But in the case of metastasis, usually they'll be, oh, there's LVI, that's another LVI. It's just everywhere. It's too good to be true. And really, it is too good to be true, right? So in that case, it's a metastasis. So that's the thing about, some tips about picking up, metastasis is really prominent LVI and reedy testis invasion. Now, there are a few other things, sort of I put at the bottom is the background, right? So not only do we want to look at what the tumor looks like, we want to take a step back and look at the background testis parenchyma, which again goes back to Grayson, because not only do you want to sample the tumor, sample the interface of tumor and background parenchyma, you also want to sample uninvolved testis background, right? Because that is another helpful thing to sort of help you figure out which category this tumor belongs to. So again, we're talking about adults now. Germ cell tumor in adults usually are malignant, and they are derived from GCNIS. So in that context, the background in most cases will be very distinctive. It has a GCNIS derived tumor background or so-called dysgenetic change, versus sex portional tumors and other types, those tumors are not derived from GCNIS, right? Therefore, the background should not be a background that would give rise to GCNIS. So in most instances, there would be normal testis background with maybe some reactive germ cell changes, some hypospermatogenesis, but you should not see dysgenetic features in the latter two tumor categories, right? So again, this is really the gist, and this is it. That's all you need to do, in my opinion, for testis tumors. Now, for joking aside, so like us differentiating, this is an adult granulosa cell tumor, this is a Sertoli cell tumor, really that's just an added bonus. But when you think about the treatment and what needs to be done to guide our clinical colleagues, it's really the diagnosis of sex or stromal tumors, and I don't see any malignant features in this one. That's really much it. So next slide. So, having that in mind, for me, the most important differential diagnosis in 99% of the cases is usually, is this a germ cell tumor or is this a sex stromal tumor, right? Because again, the treatment paradigm is entirely different. Yes, it's nice to be able to differentiate embryocarcinoma for seminoma from yolk sac tumor, but again, what'll happen afterwards? The treatment typically is the same. Of course, there's always going to be exceptions, but again, putting the tumor in the correct category is the most important thing in testis tumors. So given that, so what are the things? There's nuclear features. So in testis tumors, it's one of those rare exceptions where I would say, okay, low power architecture can sometimes be misleading, and you want to put more weight on the cytologic features of the actual tumor cells, right? Which is not true for any other organ systems, in my opinion. You always want to look at the low power architecture first, and then with a combination of high power cytologic features, right? I'm just saying, for whatever reason, testis, it's one of those where architecture, they can really look like anything, especially germ cell tumors, and that's where all this variant histology comes in. But when you look at the nuclear features itself, there's really only seminoma nuclei, yolk sac tumor nuclei, embryocarcinoma nuclei, and choriocarcinoma nuclei, right? There are really only four types. So nuclear features are super, super helpful. Germ cell tumor nuclei look very different than sex stromal tumor nuclei. So that's one thing that'll help you with this most important differential diagnosis. Two, again, is the background, right? Because again, keeping in mind that most adult germ cell tumors arise from a GCNIS-derived process. Therefore, the background should be characteristic of that potential pathogenesis, right? Versus sex stromal tumors, entirely different pathogenesis, entirely different background. Now, if for whatever reason you need additional support, then you can consider doing the IHCs. And again, this is the IUC panel I choose for this particular differential diagnosis. So if your lab doesn't have SF1, a combination of inhibin and calretinin would also do the job. But again, this, in my opinion, is the most important differential diagnosis to focus on. Everything else is really just an added bonus and fun for us. All right, so talk about this dysgenetic background, this background that gives rise to GCNIS and associated tumors. What is it, right? What is this? What are these dysgenetic changes? And they're listed here. So shrunken, atrophic seminiferous tubules, sclerosis in the tubules, so like someone's choking off the seminiferous tubules, as well as a widened interstitium. Because of the shrunken tubules, you get a wider interstitial distance, and microlithiasis. So those are the important things that I look for. So here's an example. On the left-hand side is the dysgenetic background, or you can think of it as the background that typically gives rise to germ cell tumors, which in adults mostly are malignant, versus the right side, where, if this is a sex stromal tumor, or if this is a metastasis in a slightly elderly male, the right-hand side would be the type of background you should see in those tumors that you're considering sex stromal tumors, lymphomas, etc. Right? So the left-hand side, what are those changes? So you see, decreased luminal or seminiferous tubule diameter. You see this fibrosis or sclerosis, or we call it atrophy. You see significant reduction and spermatogenesis, right, compared to the right-hand side. And not only that, in this particular instance, you're seeing GC&IS in the background, as well as microlithiasis that we were talking about, right? Widened interstitium and more prominent lytic cells. So that's what a dysgenetic background looks like. So in most cases, it should be pretty distinct. Now, one tip that I want to talk about for this one is the identification of GC&IS. So if you see a tubule with spermatogenesis, don't bother looking for GC&IS in that tubule, right? So again, what's the highest yield? Where is the highest yield to look for GC&IS? Is looking for them in the shrunken and atrophic tubules. So do not look for GC&IS in tubules that have normal spermatogenesis. Look for them in the shrunken atrophic tubules, as in this case, we'll see that they are usually at the base of the tubules. So what the background looks like, and just a quick tip about which tubules to look for GC&IS. All right, so utilization of FISH. I get asked about this a lot. When we use 12P, so these are the three scenarios I use 12P for. The first two are probably the most common. So when I'm trying to decide, okay, I have a teratoma, and this is in the postpubertal male, I know that most of them should be malignant. However, this one really has the features of the so-called prepubertal type, or the type of teratoma that's not derived from GC&IS. So I want to be extra sure that that's the correct diagnosis, and I'll use 12P in that context. Number two is, let's say, in a metastatic setting, usually, the patient has an estrogen germ cell tumor 2 or 3 years ago. Now he has this retroperitoneal mass. Is this related to his germ cell tumor? Or it looks kind of funny, could this be a different primary than a germ cell tumor, or for instance, colon cancer, lung cancer, things like that. So I use it in that context as well. Number three, which is beyond the context of this talk, is I also use it to try to get a better understanding of, does 12, also the pathogenesis of extragonadal germ cell tumors, as well as does it have a prognostic role. So that is an actively evolving arena. Again, beyond the scope of this talk, but that is another context where I use FISH and 12P. All right, so this is probably another important slide in that, what do you want to think about? What should go through your mind when you're trying to diagnose a prepubertal type teratoma in a postpubertal, right? So, or you can read it as benign postpubertal teratoma. But again, I sort of recommend thinking about it the other way. So you want to diagnose with caution, because again, just based on statistics, most teratomas in postpubertal males are malignant, right? So when you want to diagnose that really rare 3 to 5% of benign teratomas in a postpubertal male, you want to make sure that that is truly the case, because if you do that, there will be loss of follow-up, and if that's the wrong diagnosis, they'll come back with metastasis and then really poor prognosis. So again, this is the context where I think 12P is very useful. Now, if you don't have 12P, that's really not the end of the world, right? You can still make that diagnosis, but you just want to follow a really strict morphologic criteria, right? Because when you think about it, that teratoma, that really rare teratoma, is not GC&IS related, right? Therefore, you should not see anything in the testis tumor itself or in the background that would suggest GC&IS, right, derivation. So that's what this criteria means, is we don't see GC&IS in the background, there's no cytologic atypia in the actual tumor, right, microlithiasis, that's all tied into the lack of a dysgenetic background, and plus, if you are able or have this 12P testing, you can use it as an adjunct to provide further support. So that's that. So here's the summary of the so-called prepubertal type teratoma and postpubertal type teratoma. I feel like it's probably easier to think about it as GC&IS derived teratoma, which is on the right-hand side, versus non-GC&IS derived teratoma in this column, right? So when you have that, when you sort of organize your thinking that way, GCNIS-derived teratoma should have all of the features of a GCNIS-derived tumor, right? Which you should have 12p abnormalities. You'll see dysgenetic changes in the background. You'll have cytologic atypia because it is a malignant tumor, right? And in that scenario, the teratomas that you see will have very disorganized, glands, mesenchyma, just haphazard arrangement. Versus on the other hand, if the teratoma is not GCNIS derived, it will not have 12p amplification, it will not have GCNIS or the dysgenetic changes in the background. Cytologically, it should be very banal, and since this is a benign thing, then it would look very organoid, right? So if you just think about it based on the pathogenesis, I think the rest of it should just be very easy to sort of associate. Now, which I think is the way moving forward because, as you all know, the classification has changed from morphology-based to pathogenesis-based, right? What it boils down to is this tumor GCNIS derived or not? So when you're thinking about teratomas, to me, it just is easier thinking about it in the sense that is this teratoma GCNIS derived or is this not GCNIS derived? So, all right. Another question that I get asked about in relationship to teratoma is, the diagnosis of secondary somatic malignancy. So we all know this is just the background, I'm not going to go through it, but the diagnostic criteria really boils down to, do you have a single element that is proliferating beyond the 4X field? That is really it. So that's true for sarcoma as well as adenocarcinoma. It's just that adenocarcinoma, in addition to the 4X rule, has additional supplement in that if it demonstrates stromal invasion, then that can also be called an adenocarcinoma. All right, so these are just two examples. One is a somatic malignancy of germ cell tumor origin on the left-hand side, demonstrating that stromal invasion with associated desmoplasia. The right-hand side demonstrates the other example where it shows confluent single epithelial growth that expands beyond the 4X field, right? So that fits the criteria of a carcinoma in the context of germ cell tumor. All right, now what about this? So, you see this and okay, it's a glandular tumor, it's expansive beyond the 4X field, but what this actually is this is a yolk sac tumor. Now, and it shows you in this panel. So when I have a differential diagnosis of, okay, I'm thinking about maybe somatic malignancy, and usually this happens in the context of metastasis, right? Context of metastasis usually post-chemo RPLDs or late recurrences in XM. So those are the two contexts where you would be thinking about somatic malignancy for the most part. In that context, so if I'm wondering, is this yolk sac tumor or is this truly somatic malignancy, this is the panel that I use. I use a combination of GPC3, AFP, CK7 and EMA. So the top two, GPC3 and AFP, those are helpful to support yolk sac tumor versus 7 and EMA, they're more support for a true carcinoma or adenocarcinoma. Now, it doesn't always work out that way, as in this case, right? So this ambiguous glandular expansive thing is positive for only GPC3, where the 3 is negative. However, I sort of use it as a balance, that's my differential, yolk sac tumor and adenocarcinoma that's arisen from germ cell tumor. I would say, this is probably yolk sac tumor. And this is actually true for most cases. So here's another example. So the one on the left-hand side is glandular yolk sac tumor that is seen in the post-chemo context. And the morphology helps you clues you into that because it has a very endometrioid look, right? So just sort of knowing that, yolk sac tumor can potentially look like this, looks like endometrioid or secretory type endometrium, that will help you maybe consider yolk sac tumor diagnosis before jumping to the somatic malignancy diagnosis, as well as the picture on the right. It's showing you that really prominent basement membrane material, or so-called parietal differentiation. And that parietal differentiation is another feature that is very characteristic of yolk sac tumor. It's more prominent than hyaline globules. for the most part, right? So rather than looking for hyaline globules, look for that basement membrane material or that parietal differentiation. That will help you a lot when you're thinking about differential diagnosis of germ cell tumors. Both of these are examples of glandular cell tumor. Now, very similarly, again, right, when you're thinking about metastatic setting, it's a spindle cell lesion, is this a sarcoma? My tip would be, before thinking about sarcoma, think about, could this be sarcoma to a yolk sac tumor, right? So both of these are examples of spectrums of sarcoma to a yolk sac tumor. The one on the left-hand side is a little bit less cellular, it has more of a myxoid, prominent myxoid background, and it also has the so-called tumor ringlets that is very characteristic of sarcoma to a yolk sac tumor. And as you can see in this case, there's really bad cytologic atypia, which again, you know, at first glance, oh, could this be a sarcoma, right, kind of a thing. The one on the right-hand side is a more cellular example, but both of these are sarcoma to yolk sac tumors nonetheless, right? So the take-home point for secondary somatic malignancies in germ cell tumors is think about, could this be a variant histology of yolk sac tumor, which we all know has like 20 different variants, right? So could this be one of those really chemo-resistant yolk sac tumor that survived chemotherapy, rather than, oh, could this actually be adenocarcinoma or sarcoma arising out of teratoma, right? So that's the huge tip. Now, again, stepping back, practically speaking, is that a really important differential? I would say no, because when you think about treatment-wise, what can they do for the patient after those diagnoses? It's really the same. It's surgical resection, because either those, you know, endometrioid type glandular YSTs, they're not going to respond to chemo. And same thing, if you call that an adenocarcinoma, it's not going to respond to chemo either, right? So that differential is, again, more of an academic interest, potentially satisfying, but practically or treatment speaking wise, it's not as important, because at the end of the day, there's nothing you can do for either one of them. Now, the more important differential diagnosis, I would say, is this thing related to the patient's prior germ cell tumor history, right? Versus is this truly a second or an additional tumor in this patient that's not related to germ cell tumor, right? That's the more important differential. Now, what can be helpful? So I think looking at the distribution of tumor, so is, you know, let's say unfortunately the patient has metastatic disease, is the metastatic pattern, or is the distribution of tumor within the patient's body, is that a germ cell tumor metastatic route, right? Or, you know, is the distribution of tumor, for instance, a colon cancer, maybe, where the metastatic disease is in the mesentery type of a thing, right? So distribution of tumor, it doesn't really fit the germ cell tumor, therefore it probably is not related to that. So that, I think, is a lot more helpful than IHCs. So in this context, I don't use the IHCs to differentiate, you know, if this is of germ cell tumor origin or not. If that is the differential, I go straight for the 12P, right? Which is my second point of how I utilize 12P, is this is the context that I use 12P. So, you know, if that's my differential, I want to figure out, is this related to germ cell tumor or not? I just skip the IHC. I don't even do it. I just go straight for the 12P. Now, the caveat with 12P in this particular context is that, you know, yes, it works great, but there are always exceptions, right? So very rare instances, a true somatic malignancy, for instance, colon cancer that's not related to germ cell tumor, have been reported to express 12P. So it's not 100% specific. However, you know, if I have good morphology, I have a vague history of testis cancer, 12P is positive, I'd be like slam dunk. It's related to his germ cell tumor. But again, you just have to be careful that a positive 12P is not always 100% for germ cell tumor. There's always exceptions, so you got to keep that in mind. So true somatic malignancies can also have 12P amplification. So that's the caveat to that. But I use it in this context very often. So I have 4 minutes left before I use up my 40 minutes. I spent all that time talking about germ cell tumors. I just want to make a really quick note about sex carcinoma tumors. So, you know, this is one thing that I've newish that I've been doing for the diagnosis of sex hormonal tumors is based on this paper. So it's the nuclear localization of beta-catenin stain. Now, again, when you have a positive, when you narrowed it down to that sex hormonal tumor category, you're trying to figure out, okay, which one of the sex hormonal tumor it is. It has a really vague histology kind of a thing. Sometimes I'll throw on a nuclear beta-catenin just to see if I can get it to be positive in a very strong and diffuse pattern, because if I can, then I have support that it's Sertoli cell tumor, right? So that's how I use beta-catenin in my diagnosis of sex hormonal tumors. And here just are some numbers. So one, you got to keep in mind that it's not very sensitive. So a negative beta-catenin stain doesn't mean it's not a Sertoli cell tumor, right? Versus if it's positive, again, positive in a very strong and diffuse nuclear cytoplasmic fashion, I would be very confident that the specificity is approaching 100%. And in that paper, it is specified as 100%, but nothing is ever 100%. So, and another use is that can help you differentiate large cell calcifying Sertoli cell tumor, which we know is a common differential diagnosis in the context of sex hormonal tumors. So in addition to nuclear beta-catenin, I think there's this stain, this antibody ALK2, so the loss of expression will be helpful in confirming that that's large cell calcifying Sertoli cell tumor as well. And Andy Acosta has done a study of that. I think that's tweeted on Twitter. So check that out. Now, here's an example of what I consider a positive beta-catenin reactivity in the context of sex hormonal tumors, right? So in this case, this is a Sertoli cell NOS. You can see a very classic architecture, but just pay attention to the reactivity of the stain, right? So this is background Sertoli cells that is showing membranous staining versus the true tumor neoplastic, which are very strong, again, very strong and very diffuse nuclear cytoplasmic reactivity. So this is a very supportive finding of Sertoli cell tumors. Now, this is an example of how I use it. So here is a, testis tumor. I looked for dysgenetic changes in the background. I don't see any. I looked at the nuclear features. It looks really good for a sex hormonal tumor. However, the morphology is, not very distinct, right? Other than the fibrosis, everything else is really not that distinct. And here's a high power of what it looks like. So yeah, I'm able to put it in the sex hormonal tumor category, and it doesn't really have those malignant features, but I always try to do a little bit extra and see if we can narrow it down a little bit further, right? So for this particular case, I did a beta-catenin. So this is what the beta-catenin showed, right? Again, that very good bona fide positive reaction of nuclear and cytoplasmic accumulation of beta-catenin in the tumor cells, right, compared to that very nice internal control you see on the left-hand side where the Sertoli cells are expressing membranous reactivity, so that's negative. But the tumor itself is very strongly and diffusely positive beta-catenin. So given that I've narrowed it down to sex hormonal tumors, the tumor is showing bona fide beta-catenin reaction, I feel very comfortable in calling that this is a Sertoli cell tumor. And some people might even mention, well, it's very fibrotic, probably more than 50%, then this is a variant of Sertoli cell tumor, the sclerosing variant of Sertoli cell tumor, right? So that's how I use beta-catenin in my diagnosis of sex hormonal tumors. And that's newish, so I wanted to sort of go over that and share that with you guys. And this is just for bonus. So I've reached my 40 minutes. I want to make sure I give you guys a chance to ask your questions and for me to answer them. If you want, I can go over these caveats at the end, but these haven't talked about before, so it's not very important. So John, can we go into the Q&A session?
Oh, yep. Hold on a second. We've got 5 questions so far. Mm-hmm. I was just looking up whether or not we could get 12p in the UK, but it's not something I've ever requested. So, so one of the questions is 12p helpful in the diagnosis of primary extragonadal germ cell tumor?
Yes, it's helpful, but is it necessary? Most likely, yeah, I guess it depends on who you ask. So, I don't really go for it all that often. For instance, mediastinal tumor. a mediastinal germ cell tumor, for example, if it's malignant, if it comes from malignant, again, you'll know that just based on morphology, it's probably of the malignant derivation. But is there a utility in the diagnosis of it? Probably not. But is there utility in understanding the pathogenesis as well as potential prognosis of the patient? I do think so. So I may consider doing 12P in the context of extragonadal germ cell tumors, but it's not for the diagnosis of it, because I think diagnosis we can make a diagnosis based on Agent E and some IHs if that's necessary. But for 12P itself, not necessary in most cases. But I do them again for the context of just having a better understanding of what's the pathogenesis and what that means for the patient later on.
Okay, so another question. Do you mention if the teratoma is mature or immature? We get this question from clinicians.
Yeah, so that is a really great question. So again, when we're thinking about the context of post-pubertal teratomas, or the ones that are GC&IS derived, we absolutely do not need to separate if it's mature versus immature, right? Because if a tumor is GC&IS derived, no matter what it looks like, it technically is malignant. So an immature teratoma in the context of GC&IS derived teratoma, it's malignant. Same thing. Even if it's mature appearing teratoma, that mature appearing teratoma derived from a malignant tumor, right? Derived from a malignant GC&IS process. Therefore, no matter how mature it looks, its behavior is malignant, right? So in the context of GC&IS derived teratomas, we do not need to separate immature versus mature. Now, where it gets complex, it's in the other type, right? Where a teratoma is not derived from GC&IS. Now, in that pathway, it's actually very similar to the ovarian teratomas, right? So in that context, I separate it, and I think it is recommended to specify if it's immature versus mature teratoma in the context of not GC&IS derived teratomas. In that instance, mostly in the pediatric testis context as well. And you can think about it parallel to the ovarian teratomas, right? Which we do separate immature and mature teratomas. So that's how you want to think about it. And again, in the testis, is this GC&IS derived or not? One is yes, one is no. If it's GC&IS derived, absolutely no significance in differentiating immature versus mature. However, if it's not GC&IS derived, which is very similar to the ovarian teratoma context, then we try to separate immature versus mature. Now, currently, the differentiation or grading per se, grading of immature teratomas, we are utilizing the ovarian method. Archaic, yes, but that's what we do and that's what we have for now. So great question.
But also the question would happen in the post-chemo RPLNDs. So would you comment on if it's chemo, so if it's all mature?
So whatever teratoma is happening in the post-chemo RPLND, now teratoma is a malignant one, right? Because it started as it's a malignant tumor. So in that context, I still don't separate immature versus mature, because that teratoma is a metastatic one. It has malignant potential. So again, there's no need to distinguish in that context either.
Okay, so the next question, GATA3 is the best I don't know if this is a question or a statement. GATA3 is the best immunostain for placental tumors in testis. Glypican-3 is the best for yolk sac tumors.
That's a really good question. So, for trophoblastic tumors, in my opinion, trophoblastic tumors are very distinct, right? Because when you look at the nuclei, they're trophoblastic. So do we really need stains? No. But if I would like to have a positive stain for trophoblastic tumors, yes. GATA3 is probably the best one in the penis, because HCG, just like AFP, I don't use it at all because it's just too dirty if you have that serum elevation correlation. So, but yes, if I have to pick one stain to use for trophoblastic lesions, GATA3 would be my go-to. Inhibin works as well if you don't want to use GATA3, but inhibin I think is a little bit less sensitive, but GATA3, very nice. And same thing for choreo. You know, if you're even, because placental tumors in the testis one is pretty rare. So the more common trophoblastic tumors you're going to encounter in the testis tumor realm would be choreo or variations of choreo, the so-called monophasic choreo, again, occurring more commonly in the background post-chemo setting. And you want to differentiate that from seminoma, from solid yolk sac tumor. Yes, Gana-3 would be the one to go for. I agree with that. Glypican-3, is it the best? Yes. So compared to AFP, it's not as specific, but again, just trying to avoid that dirty background, you know, that I do think if I have to pick one stain for YST, GBC3 would be it. So I agree. I agree with that.
Okay. So do you have a cutoff of size or extension of findings to diagnose seminoma with scar, potential partial regression in pure seminoma?
That's a really good question. So if I see viable seminoma and I see scar on the side, I sort of just mentally block out that scar. Because again, it just happens. You know, germ cell tumors, they regress. It's part of the business. So unless it's very striking, where you know the gross measurement is actually most of the scar, then I sort of do subtractions of it. But in most cases, you'll just see most of it is viable seminoma with a little bit of scar here and there. I just pretend I didn't see them.
And now the next question is a cut-up question, or a grossing, as you say in the States. Given the fact that the margin of the spermatic cord is often ragged due to retraction, would you advocate inking the margin, as the on-face sampling may not encompass the whole circumference of the cord?
That's a great question. So for me, I actually don't recommend you ink the testis at all. But I do understand that there's retraction concerns and all that. So a tip that I personally use is, yes, a lot of retraction happens at the margin. What I do is, you know, here's the cord, right? I sort of massage out the margin area, and then I cut then. So I sort of, even though it's retracted, I manually push it out to the front, and then I take that section. So I find that easier than spending the time to ink the thing, and then ink gets everywhere, and you know, just dirty grossing and all that. So I actually don't recommend inking the testis at all.
But you have to say that margin, I don't think I've ever seen that margin ever involved. So it
does happen though, but you're right, very, very rarely, because usually if it's there, you should see it grossly. However, we still do it to catch the little lymphovascular invasion at the margin, right? So we have seen, but you're absolutely right. Most cases, it's really a technical documentation purpose. It's going to be negative, but in some cases, it might happen.
You could just, I mean, what I would normally do is cut the margin, put the cut side down, and if it's positive, then you could always flip it and level it off. But you know, you're never going to do that, are you? Right, okay, let's move on quickly. If one-sided germ cell tumor is diagnosed and the lateral testis shows GCNIS, what would this result in clinically?
That's a really great question, because why preserve fertility, right? So if one side of the testis is already out, and on the other side you have GCNIS, which actually happens, right? Because if you have, you know, germ cell tumor on one side, it increases your chance of having it on the other side. So in that context, they'll try to preserve fertility. So maybe what they'll try is, you know, if it's only GCNIS, maybe they'll try to just radiate it for now, and save the testis. So that's what I think will happen. That's a really, really great question. Another context, so that just reminded me, another important context, again, I didn't really talk about, is regressed germ cell tumor, right? So the diagnosis, it's been talked about, so I didn't want to talk about it here, but I just want to briefly mention that if you have regressed germ cell tumor and you have scar, so if you have already proven metastatic tumor and you have a scar, that's not diagnostic of a regressed germ cell tumor. However, I would recommend you reduce your diagnostic criteria in that context, because if there's any hesitation that scar is not regressed germ cell tumor, they're going to go after the other testis. So again, thinking about preserving fertility, etc., saving the patient's other testis, that's another context where I think might potentially come into play, is the diagnosis of regressed germ cell tumor. Now, if you don't have confirmed metastatic disease and you just have an incidental scar from pain, right? So there's no confirmed history of metastatic disease, just this incidental scar. my diagnosis, my diagnostic criteria for calling that scar regressed germ cell tumor would be a lot higher than say the patient already has a biopsy-proven metastatic seminoma, right? So that's the thing to sort of keep in mind is, the diagnosis of regressed germ cell tumor in different contexts, possibly relating to preserved fertility.
So someone's asking, they've obviously been reading the literature. Can you say something about the matter of renaming PNET of the testis?
Yeah. So Michelle Kirsch and Dr. Albright, along with the neuropathologist, I think, wrote a really nice paper about recommending the renaming of PNET, and which I think is happening. So I think the WHO, as well as the newly out FACTable. So the new stuff that'll be coming out in 2022 will have the new name, which is embryonic neuroectodermal type tumor, so ENT for short, rather than a PNET. So again, similar to this misnomer of spermatocytic seminoma that got changed to spermatocytic tumor, I think the old PNET in the testis world is undergoing the same thing, a nomenclature change, but it's the same entity and the diagnostic criteria remains the same. It's just that there's a name change.
All right. So we've got what is the best marker for GCNIS? So they're talking about PLAP, CD117, OCT3/4, or SALA4.
I love that question because it ties into my little bonus IHC caveats. So my favorite GCNIS stain is OCT3/4. So that's my favorite stain of all time is OCT3/4. It's just so clean, so easy to use, relatively specific. Well, not relatively specific. I would say it's very specific. If anything is approaching 100%, I would say OCT3/4 is one of those. So OCT3/4 is my favorite stain. PLAP, I was never taught to use it, so I don't use it, and it's fallen out of favor. So don't use PLAP. But the one thing I wanted to point out, and that's the reason I have this bonus slides here, is CD117. So CD117 is toxic. Don't use it. Don't even, toxic in the germ cell tumor world. I love it in the kidney world. But in the testis tumor pathology world, forget about CD117 because there's so many potential pitfalls with CD117. So one, when you're looking for GCNIS, CD117 may occasionally stain non-neoplastic germ cells. So sometimes reactive germ cells will pick up CD117. So if you're really not careful about the morphology and relying on CD117, it'll pick up false positives, right? So when it's actually just reactive germ cells, not GCNIS, but you might be misled to calling it GCNIS because of that CD117. Now, another example is spermatocytic tumor, right? So let's say you have a tumor, 60-year-old male, and you're thinking, well, is this seminoma versus spermatocytic tumor? Both of them are actually positive. So again, if you're using one stain, depending on what diagnosis you're thinking of, it may be the wrong one because there's CD117 reactivity. So not only that, yolk sac tumor can be CD117 positive, right? So yolk sac tumor, seminoma, as well as spermatocytic tumor, all three can be positive, right? So what's the point of using that? So absolutely. So in addition to that, I have seen, CD117 used in the context of germ cell tumors in the mediastinum, for example. The tumor is positive for CD117, it's called germ cell tumor, but actually it's melanoma. So all of that put together is just to try to scare you and to do not use CD117 in testis tumor. Just forget it. Use OCT3/4, use GPC3, use GATA3. Everything else is better than CD117.
I think you've stressed that enough, or throw it in the bin.
Do not use.
Excellent. So the next question is, do you routinely use immunohistochemistry to confirm or delineate the different components of a mixed germ cell tumor?
No, right? Because remember that the broad overview is really when you get down to germ cell tumor. I mean, germ cell tumor is a germ cell tumor. Mixed germ cell tumor with 60% embryonal, 10% yolk sac tumor is not any different than mixed germ cell tumor, 70% embryonal, 5% yolk sac tumor. I know it doesn't add up to 100, but that's an example of that, right? So again, once you get to the categories of tumor, I think the use of IHCs is really just trying to see if you can narrow it down further and as accurately as you can. But again, in the practical sense, I don't. So in most cases, we find that we just use morphology for the most part. Sometimes we'll have a question, is that teratoma? or is that a little bit of glandular yolk sac tumor? But again, when you take a step back and think about the context, what's the difference? You're only altering the percentage of teratoma yolk sac tumor by maybe 1 to 5%. Is that really worth throwing on the immunos, waiting an extra day, and then having to think about it? Harder? No. So, but great question. But of course, in some instances, I find it would be poor fixation, right? Is you get sections and you're like, what is this jumbled stuff, right? So morphology doesn't really work in that context, and you're going to try to throw stains on it. But just keep in mind, poorly fixed tissue really is not a great section to stain with IHCs, right? So a negative stain in that poorly fixed crack doesn't really mean that the tumor is negative, right? So again, going back to the first point is your maximum success really occurs with prompt fixation. Just make sure it gets in the formalin in time, and really would save you a lot of hassle down the road and the need to use IHCs. Really great question.
And I think that's talk about fixation. Someone from Germany says if the testis is fixed in Bowen solution, which is used in Germany, nuclear stain of OCT3/4 may fail. I mean, we use Bowen's for the diagnostic biopsies for infertility, but I don't think we tend to get Bowen fixed testes.
Yeah, that's a really great question. So I personally don't have that much experience with Bowen's, but if your concern is the lack of nuclear staining, D240 works too. So D240 should replace, if you want a membranous stain for GCNIS or seminoma, pick Potoplanin. Potoplanin works much, much better. So if OCT3/4, you're worried that OCT3/4 would not be positive because it's been Bowen fixed, try D240 because it would be a really strong and diffuse membranous pattern. So that would be my recommendation. But I have no personal experience with OCT3/4 and Bowen fixed material.
So I was going to ask a question myself, because this is there a good resource for the for a table for the immuno table, because it's getting very complicated with all the different immunos that are now available. Is there a good resource, a good paper or review?
So a fascicle, the test AFIP fascicle will be hopefully coming out in 2022, and there is a massive table of all the stains that have been done in germ cell tumor. So yes.
We love a good table of immuno. That's what we love. To photocopy it, stick it on the wall, and then try and work it all out.
Exactly. But there will be one, yes. So that's the one I can immediately think of.
Excellent.
But and a word of advice on using immunos. So you don't want to use it in the context of, oh, I have this testis tumor. I don't really know what it is, so I'm just going to throw GATA3, GPC3, OCT3/4, and just hope that it'll all work out. What's recommended is you sort of look at the tumor, look at the cytology of the nuclei, and usually you'll be able to narrow it down to just 2 differential diagnoses, right? So usually it's seminoma versus yolk sac tumor, embryonal versus yolk sac tumor, and then you only do a limited panel of usually 2 stains for that 2 differential diagnoses. So that's the way I would encourage you guys to think about the utilization of IHCs, is try to narrow it down to 2, maybe even 3 differential diagnoses. Then you pick the panel that would work for that, rather than I have a testis tumor, I'm just going to throw all the germ cell tumor markers I've heard of and figure that out. Because again, nothing is ever 100% sensitive or specific. So you might have some overlap, which, just might not work out if you have that many stains. You get just immuno overload. So.
But it does give you an extra day to think about it.
I know, stall. Yeah, I understand.
So one of the last questions, the yolk sac tumor component should be determined by IHC because it doesn't respond to chemo. Is that right?
Sorry, can you ask that again? What?
So they're saying that it's important to identify the yolk sac tumor because it doesn't respond to chemo, and they're asking if that's a correct statement.
I think in the context of metastasis, it's important to identify the non-teratomatous elements, right? So it's not just yolk sac tumor; it's embryonal carcinoma, it's seminoma, it's choriocarcinoma. So because again, when you think about, okay, if it's already metastatic, then you're trying to get a glimpse of what that metastasis is, right? So if you have whatever non-teratomatous germ cell tumors, that can be treated with additional chemotherapy, versus if it's teratoma, it needs to be excised. So it doesn't matter if it's just yolk sac tumor or if it's just embryonal, any non-teratomatous elements in the context of metastasis matters. It's just that knowing that serum
tumor marker levels is very helpful in one, trying to come up with a more definitive diagnosis when you're thinking about, could this be X or Y? And two, sampling of it, right? So again, if you have elevated AFP and all you're seeing is just teratoma, you may want to consider looking at the specimen and see, oh, did the grosser miss a solid fleshier area? Of course, some teratomas can secrete AFP, so it's not definitive, but that's how I would use that information. But bottom line is, any non-teratomatous germ cell tumor matters in the context of metastatic disease. And, you would want to diagnose those non-teratomatous elements. However, you need to morphology or additional IUCs.
I think we've come to our end of our hour, and you have done extraordinarily well answering 16 questions. A new ISUP record. Thank you very much for talking to us on a subject which I think you've just scraped the surface. We're going to have to get you come back and give us some more when the WHO classification is out, and it's and we all scratch our heads and saying, why have they done this? Why have they done that? We may need someone to explain it to us.
I would love to do that.
Thank you very much for speaking to us, and good night or good morning or good afternoon to everybody who's listening. Thank you.